Welcome, and thank you for joining us for the RSNA 2024 Radiology Reimagined demonstration. Hi, I'm Alicia Dami from Stanford University Medicine, and I'll be your guide for this introduction. Artificial intelligence and adjacent emerging technologies continue to make strides in radiology. AI can transform healthcare and address both computer vision and non-diagnostic tasks. RSNA has organized this demonstration under the direction of the Radiology Informatics Council to highlight ways that AI is already impacting the care we provide, to show how AI and other emerging relevant technologies will change the way radiologists work, and to explore what is needed to deploy and maintain AI effectively. As part of this demonstration, we again invited vendors of imaging, reporting, and AI systems to showcase tools that are currently in use or coming soon. Vendors were assigned to specific roles based on their capabilities and organized into 3 functional teams around fictional clinical scenarios. In each scenario, from the perspective of a radiologist, we go through several tasks aided by AI and supported by evidence-based care and diagnostic radiology. These tasks span the radiology workflow, from pre-acquisition to post-processing to reporting. Such tasks include faster protocoling and image enhancement at the pre-acquisition stage, the use of an AI orchestrator to integrate all AI tools, prioritization of work lists, as well as overlays on images for segmentation or completing measurements. Let's take a look at sample ways AI can improve the radiology workflow. Prior to image acquisition, AI facilitates protocoling, making it faster and more consistent. At image acquisition, AI aids in the reconstruction of MR images, an intense area of research. Algorithms aid in enhancing MR image resolution, reducing scan times. An essential component for successful AI implementation is the AI orchestrator, or traffic cop. The orchestrator streamlines integration of AI tools, making sure the correct imaging exam is presented to the right AI model. The AI orchestrator returns the results to the correct system. Another way AI can enhance radiology workflow is automating the prioritization of reading work lists. Interpretation worklist managers consolidate input from variables including workload and radiologist availability to allow timely review of results for urgent findings. Finally, the AI results are presented to the radiologist to review, edit, and accept or reject. AI results can include overlays such as segmentations or measurements on an image. AI results, such as ARIA findings or PI-RADS assessment categories, can also be sent directly to the report. The patient scenarios in this demonstration were designed to showcase actions for both acute and non-emergent findings. These cases demonstrate how using AI can improve efficiency of evidence-based care throughout the radiology workflow. You are about to participate in one of 3 scenarios: OB ultrasound and PE workup, prostate MRI with radiology pathology correlation, and ED trauma to ARIA workup. As you progress through our clinical stories, please excuse inconsistencies as we assembled imaging from several real patients. Additionally, some of the products that you see are either prototypes or still under development. Assembling the demonstration underscored the crucial role of interoperability standards and frameworks such as DICOM, IHE, and HL7 FHIR for the effective deployment of AI in an integrated workflow. These standards facilitate exchange of image annotations, findings, measurements, and assessment categories. Semantic standards, such as RSNA's RadLex, common data element modules, and RAD report templates help ensure clarity and interoperability. We are about to begin with one of our 3 clinical scenarios. Please remain seated for the live demonstration, and welcome to Radiology Reimagined. Okay, last but not least, this is our 3rd clinical scenario. My name is Alicia. I'm a 4th-year radiology resident at Stanford. And we met earlier during the video. Now that I've heard my voice like 20 times, I'm going a little stir crazy. I don't know about you guys, but this is my 3rd year as docent and 2nd year as clinical champion. And it has been so much fun and just so cool every single year to get to work with our vendors. And I'm so excited to show some of the stuff that we've been working for the last 6 or 7 months on. So without further ado, we'll get into the clinical scenarios of 2 separate patients. So the first scenario is obstetric imaging and the second is thoracic imaging. And so with that being said, we'll get into our first patient. So she is Sarah, she's pregnant, and she is going to her OB appointment for a routine 20-week anatomy ultrasound. So the first step in the workflow, of course, is to obtain the images. So images are acquired by the technologist and the results are first viewed in the BioticsAI screening assessment portal. So BioticsAI acts as a diagnostic co-pilot during the ultrasound screening, providing feedback on completeness and quality of the fetal ultrasound examination. So this is happening before, the radiology resident, before the attending is even taking a look at the study. It is at the point of care when the technologist is scanning the patient. So the BioticsAI algorithm aids in several tasks, including providing quality assurance on the completeness and quality of the screening, again, before I even as a resident take a look at the exam, ensuring appropriate capture of all standard fetal anatomical planes and presence of anatomical structures, because as we know, for all the different gestational age scans, we have to obtain X number of planes. And also, in addition to identifying key anatomic structures, detecting potential fetal malformations. So not just routine anatomy, but pathology as well. So think your VSDs, your renal agenesis, etc. And so the operator has access to a quality review panel on the right-hand side of the screen that we can see to determine if the screening was completed with appropriate planes, to validate presence of key structures, etc. And so looking at our pane on the right-hand side, it looks like we have a couple red flags. So let's go take a look. Looks like we have a flag for the 4-chamber view that shows that the mitral valve and the tricuspid valve were not well shown. So even before the radiologist has shown these images, the technologist knows to go back and gets a better view. And so once we're happy, once we've acquired all sufficient view planes, we can then export the study as a DICOM result. Images are sent via DICOM to the IRM's Universal Viewer. IRM's Universal Viewer provides secure web-based access to comprehensive medical data on any web-enabled device. So that's anytime, anywhere access for clinicians and radiologists, which is pretty neat. IRM's Universal Viewer also adheres to international standards such as IHE profiles, DICOM SR, AI results, HL7, FHIR, etc., ensuring smooth interoperability and efficient exchange of image and text. And interoperability, as we know, is the name of the game. So the IRM Health Engine VNA, the Vendor Neutral Archive, serves as a central hub in Sarah's clinical workflow by efficiently archiving BioticsAI's findings and related data for retrospective analysis and future research, consolidating the DICOM, the non-DICOM, and the unstructured data, as well as clinical records, into a centralized repository, ensures seamless data exchange and enterprise-level management, which I just think is so cool, all in one place. So coordination, as we all know, coordination, interoperability needs to be there for all these things to work. You can have as many tools as you'd like, but things need to work smoothly and seamlessly. So coordinating patient care requires tight integration at the end of the day between systems like our PACS, between the EMR, reporting, etc. And a lot of you folks know, of course, that the system speaks standards like DICOM, HL7, FHIR, but there's a product that plays a particularly strong role in a scenario like this, and that's the Qvera interface engine. So Qvera plays a role behind the scenes to enable said integrations, which is a very key component of interoperability. So the interface engine by Qvera is a sort of translator, it's like a glue, which kind of cements these standards between systems to ensure all the systems can just communicate very effectively. So that's our Qvera interface engine. Okay, and that wraps up scenario number 1. We'll start moseying on over into our second clinical scenario, which is chest pain, adult chest pain. And we have a patient, a 58-year-old guy, his name is Adam, and he has a 30-year smoking history. He comes into the ED with chest pain and difficulty breathing. So we're getting some thoracic imaging here. So a CT chest was obtained, sent via DICOM to our PACS. In this case, the PACS is the Siemens Healthineers Single Carbon Space PACS. And so it's sent there for storage. Also sent to our orchestrator, and that is our Qvera interface engine, which then sends images to the appropriate algorithm, which is going to take a look and analyze the images. So in our particular case, the algorithm that we are using is the Siemens Healthineers AI Rad Companion CT chest algorithm. So while we wait for our algorithms to process our imaging, note that the radiologist uses the Epic Radiant workflow to review the imaging workflow. And here we see a column titled Reading Priority. And so if we hover over a marker, we'll see a pop-up indicating that there's some sort of priority, some sort of potentially emergent finding. And so as a radiology resident, when I'm on call, I haven't even taken a look at the study yet, but this algorithm has already flagged some potentially emergent findings. So some triaging tools, if we think about efficiency in our clinical practice, especially as volumes continue to skyrocket, it is helpful to have this triage, so I know to take a look at it a little bit earlier because there might be a potentially emergent finding. So the study is reprioritized to the top of the list so that I can take a look. And so we can go ahead and open the study now. in our Siemens PACS, and we'll review the AI results in the Fovia AI Cockpit viewer. So in the Fovia Extreme AI Cockpit viewer, we'll get to take a look and modify, accept, reject all the different findings that our algorithm, our Siemens created algorithm has issued for us. So going back to the algorithm, the Siemens Healthineers AI Rad Companion algorithm analyzes the CT chest for the following: presence of PE, so heat maps and a 3D view are also included, located on the right-hand side there. Measurement of aortic diameter with reference thresholds as well. And as a radiologist, I can modify the measurements. I can modify the diameters if they're not to my liking. So I can do this in real time, change those calipers. Next is automatic detection and measurement of pulmonary nodules and emphysema. So a little bit more bread and butter kind of outpatient thoracic imaging stuff. And so we can see on the left-hand side that there's a blue column with all these different findings with several nodules, several pulmonary emboli that are identified as well. So I can go in, click through all of these, accept, reject, modify, change the calipers, etc. And once it's all to my liking, I'm going to go ahead and accept all the findings. So we can see bounding boxes as well, and then the magnified view of what the finding is on the upper right-hand corner. And several nodules were found, which I did not have to dictate, which is great. And we'll talk a little bit more about reporting as well. But when thinking about efficiency, how we dictate, I think, is a major kind of bottleneck sometimes in a busy inpatient setting. So I'm going to agree, accept these findings. So pulmonary emboli, several pulmonary nodules, just at the calipers, and I'm happy. So the results will be sent back to Qvera, our AI orchestrator, which is going to send them back to our Siemens PACS for storage. So briefly, a little bit of an aside, a little review. AI results can be presented in two ways. One is DICOM SC, so secondary capture, and structured reporting is the second, SR. So if the radiologist can accept or reject the AI findings, the AI results are represented as DICOM SR. And in contrast to that, in this case, the findings are automatically sent to DICOM as images, which cannot be edited directly by the radiologist. And so this is secondary capture SE. And so coming back to Qvera, Qvera also shines in this domain, as Qvera can convert DICOM SE results, which are understood by PACS, into FHIR so that the data is understood and other downstream systems like the EMR. Okay, so back to our report. Now it's time for report generation, like I alluded to earlier, using smart reporting. And so we're going to efficiently create a comprehensive report. So our report, and I haven't done a thing yet, but our report at this time includes a detailed description of the pulmonary nodules and recommendations pulled from FHIR guidelines as well. 2 is quantification of emphysema and its distribution, not seen in our case, but this is a possibility. 3rd is a description of early interstitial lung abnormalities and changes and recommendations for PFTs as well. So again, nice bread and butter outpatient thoracic imaging stuff. And again, none of these measurements, none of these observations, none of these nodules were created by me at all. This was all auto-generated, which I just think is so cool. Okay, so switching gears a little bit, generative AI, I'm sure that's something that we've all thought about or heard about. And so let's see how we can generate text directly from the image compared to our prior workflows where we sent the radiologist approved findings to the report for review. And so this is where the HOPPR CT foundation model comes into play. So we will throw on the HOPPR CT foundation model, which will perform a secondary analysis of Adam's CT image. So here we see that the HOPPR CT model confirms pulmonary nodule findings that the Siemens AI algorithm also demonstrated, and displays the AI results in the Fovia Extreme AI Cockpit viewer. We also see HOPPR's pre-populated radiology report, so including findings and impression sections with descriptions in these gray boxes. We can click through these gray boxes and the corresponding radiology finding is displayed in the viewer via the interactive multimedia reporting capabilities. And I think this is so fun, and I think we're going to see a lot more of this in the future. So we can interact with these links and travel to the image of interest. So for example, if there's a hilar mass or mediastinal mass, we can jump to that and I jump to my finding. I can also in real time interact with those calipers and change those calipers right then and there. And as I update the measurements of that nodule, of that mass, for example, the report text changes to match the new measurement. So that also saves time. I don't have to go back into the report and change those measurements. That will automatically update. And so reviewing and generating the report, this kind of cuts down on some of that time there. Okay, so again, I can interact, interact with the pre-populated AI results. I can accept, I can reject. And again, none of these were dictated by me. None of these were dictated by me, which I think is so interesting. Okay, the clickable links on the right-hand side, which we've been going through, correspond to the exact slice of that finding. So preview of the IHE interactive multimedia reporting. And so I think, again, we'll see kind of more of this to come. I think it's a really cool tool. Okay, and so we'll turn our attention to the HOPPR Copilot next, which is a query engine. So another tool by HOPPR. And so here we can ask the model, sort of chat GPT style, some questions to learn more about our patient and the pathology. So what we'll do is we'll dictate a question to the model, and HOPPR will give us an answer. So the question that we're about to dictate is: a prior screening CT chest from 1 year ago showed no nodules for this patient. What is the differential diagnosis? Okay, so we're going to dictate that in, and it's going to start talking to us.
Development of a mass at the right hilum, multiple nodules, and the enlarged lymph nodes with a previously negative CT. The differential diagnosis includes a primary lung neoplasm, such as bronchogenic carcinoma.
Within seconds, I have a whole differential diagnosis. And as a radiologist, what I can do is I will carefully review this. If I feel like this is valid, if I feel like this is something I can use, I can copy and paste this into my report as well. So yeah, directly copy and paste. I can modulate it if I wish, but very quick. Very impressed by how quickly this was kind of thought through. Okay, and so the next section of this talk is recommendations. So as a resident, you know, another thing that I think about and is kind of stressed to us at Stanford is our job is to create very thorough and thoughtful and accurate reports, but it's also to do our best to make sure that the clinicians are informed of these findings, especially for findings that might not be emergent, things that potentially could fall through the cracks. So recommendations is where we're heading. What are the next steps? So going back to Adam's CT chest, you know, I reviewed everything. I reviewed all the AI enhanced images, findings. I decide that some of the pulmonary nodules are potentially suspicious and need some follow-up here. So we will travel back to EPIC, the patient summary window. Here we can see the AI-generated comprehensive medical history and current symptoms. There is a generative AI solution that works behind the scenes to extract relevant information from our patient's charts. We see that this patient summary interface displays Adam's smoking history and family history of lung cancer, which are important for FHIR criteria, of course, so that is pulled automatically. If we scroll down, we can see that imaging findings are shown here as well, which were filed via FHIRcast in real time. RSNA common data elements and RadLex terms are used as the basis for a shared representation of radiology findings to make this possible. So I review these findings as a radiologist, I hit the sign button, I exit the workflow. And now I think what we'll transition to next is thinking about our own practice and follow-up and recommendations being brought to the attention of the ordering provider in a timely fashion. And I know how it's done at Stanford, but of course done in different ways at different institutions. So one solution to this, one very helpful tool is CDS hooks. CDS hooks can help us bridge our imaging reports and the EMR. So this EPIC integration will demonstrate the value of CDS hooks to communicate actionable information from the report to the ordering provider. So the radiologist doesn't really have to do a thing. And we are now using the perspective of the ordering clinician. So we're before rounds. Ordering doctor will log into our computer. It's 6 in the morning, logging in before rounds. And I notice an alert in the inbox. The message contains an update that Adam's CT report was finalized, and a link called the address recommendation is available for my review. So we can see the finding and recommendation for follow-up imaging if we use the address recommendation. So we'll click to the link where we'll travel to our practice advisory for this patient. The card references accession number for the study, for Adam's study, the exam date, and features the pertinent impression point from the CT chest report. So not the whole report, but just what the ordering clinician needs to know what is important. We see reference to what we said was suspicious, a suspicious lung nodule, and also the corresponding recommendation for follow-up. And this recommendation is derived from the FHIR criteria on both information from the report and clinical history from the EMR, the smoking history, and the age that were pulled. So that is how the two sources of data are bridged, the EMR and the report. Again, I did not have to do anything. The card also provides a suggestion to place the appropriate orderable with calculated date of next exam as well. So hopefully saving a couple phone calls asking, when the next follow-up imaging should be. And so thanks to CDS Hooks, the ordering provider can place the order in for a follow-up CT based on that recommendation, and ultimately with the goal of preventing a lapse or delay in follow-up for the lung nodule.